I'll get a consent to click on. Thank you. And wow, what a turnout for this topic about what happens when you call 911. It's amazing to see so many people. And I know of lots of other people who wanted to be here who are going to wait for the recording because of conflicts or whatever. So I am going to start off by mentioning that I think I've got everybody on mute. It would be appreciated if you would stay on mute unless you are called on to say something, except for our panelists, of course. It'll just keep background noise down. And I can't thank these guys enough for donating their time to the Funeral Consumer Society today to help with and shedding some light on the way the 911 system works. This webinar is one in a series that we started about 2 years ago. We've been doing different topics over the last 2 years quarterly on all kinds of things like talk to a funeral director about the coroner system, about death doulas, about hospice. And so, as I know you probably know from all of our emails and such, that all of those recordings are available on our website and on our YouTube channel. So today's is recorded off also. As questions come up, I think with this large of a group, ideally you would put your questions into the chat, and then several of us will feed those questions to our panelists. If it is something that you'd like to explain or you'd like to raise your hand, feel free to use the little reaction button down at the bottom and raise your hand, and we will watch for you that'll bump you up to the top of the screen, and we should notice that you've got your hand up if you have something that you'd like to share. And on that topic, if you have something that you want to share, please remember that this is being recorded. So by raising your hand and speaking out loud, that will bump your face onto the screen. And so you will be part of the recording for the future. So keep that in mind. And also, if you keep in mind that when you're asking a question, that it's something that would be useful to others also. A personal story is fine, but if it's really just personal, then that's something you could put into the chat directly to one of the panelists, and they could respond privately either during the program or later on. So thank you for considering the nature of your questions before you ask. So back to our presenters that are here today. We've got Chris Chi, and I'm going to let each of them introduce themselves and share their background and what their story is. The format will be each one will introduce themselves and then share a little bit about a day in their life of this kind of work, what piece of the puzzle they are, and then we're just going to open it up to questions, because I know there are gazillions of questions out there. I get asked questions all the time in my work with out-of-the-box end-of-life planning, and also as a member of the board of the Funeral Consumer Society. So this is going to be educational for me also. Speaking of the Funeral Consumer Society, we've got other board members here. Maybe you could just speak up because you're on 4 different pages.
I'm Jill Ross. I'm the vice president of the board working with Sue. I'm passionate about this work. I work in senior living as well, so I do this personally and professionally. So thank you for being here. One thing I want to mention as well is anything that is in the chat is also public. That will be a part of the recording. So thank you. Thank you, Sue.
Thanks, Jill. And then I know I saw Dawn.
Yes. Hi, I'm Dawn Kirkwood, and I am a relatively new member of the Funeral Consumer Society board. My role and my interest in all of this is primarily in outreach and getting as much information out as possible so that to help people make good decisions on their end-of-life matters.
Thank you, Dawn. And missing anybody else that's here from the board? Okay. All right. that order of business. I should tell you that my name is Sue Mackey. I assumed everybody knew, but I'm president of the board and have been for the last couple of years, and proud of what we're putting out there as far as educating funeral consumers, which at some point in time will be all of us. So, okay, so we've got Chris, we've got Laird Wolf, who is a retired ER doc from the Boulder Community Hospital, now called Boulder Community Health. And Robert Putfark is with us. He's the EMS captain for our Arvada Fire Department. And we're expecting Steve Silberman, who is a dispatcher for Boulder County. I don't see him present at this point. So we can just get started. And I think we'll lead off with Chris, who is a clinical education specialist for American Medical Response, responsible for training EMS people. So I'm going to turn it over to you, Chris.
Hey all, my name is Chris, and my formal title is clinical education specialist. And so what that means is for the ambulance service for the city of Boulder and the Western County of Boulder and then the city of Longmont. My job is to take people who have hit the minimum certification level for EMT and paramedic and train them to be a successful EMT and paramedic in our service, as well as ensure that the clinical care, the actual medical care that we provide to people is top notch, and answer questions that people like you have.
And Chris, are you in charge of the training for everyone in Boulder County, or what?
Sure, yeah. So I
on
do the training for all of the ambulances that you would see in Boulder City. But there's several different agencies that are operating all within the county. And so if you are living in, say, like what's called the BCFFA, or the Boulder County Firefighters Association, that's a lot of volunteer agencies like Netherland and Indian Peaks and Lefttown and Jamestown and whatnot. Those are all places that AMR provides the ambulance service to, but you could get an ambulance from a variety of different places. For example, Captain Putfark is on here, and he would be able to provide ambulance and do the training for anybody that's responding with Arvada. So a pretty big variety.
And so are there other services, other ambulance services besides AMR?
There's ambulances that can come from, so like, for example, so AMR is a private ambulance service, and we only do ambulances. A lot of places in the state, you'll see ambulances might be affiliated with a hospital service, or they might be affiliated with a county, or they might be affiliated with a fire department. And you might have someone who works as both a firefighter and as a paramedic or EMT.
I'm just thinking of some questions right off the bat. Difference between an EMT and a paramedic, or is there one?
Yeah, there's a pretty good difference. So EMT is kind of that first level of training that you have to accomplish in order to work on an ambulance, and you learn things about, what is like kind of a normal person look like, and what does their vitals look like, and you learn how to take vitals and do pretty basic assessments and complaints, and you can manage things like you can do CPR, and you can do breathing for people, and you can give some medicine, sometimes like epi, and help with a lot of emergencies. And then you can also go to paramedic school, which is the next level up from EMT. Most commonly, there's actually a couple different levels, but in Colorado, most commonly go to the paramedic level, and that is equivalent of about 2 years of education for college. So a lot of people will accelerate that program and do it pretty quick. And paramedics do like cardiology, so they'll look at the EKGs, and they can do airway management, so they can do like the tube to breathe for you, and a lot more medications and a little bit more advanced assessments.
So how do you know what you're getting when you call 911? What level of care you might be getting, or do you have any?
Yeah, that's a great question. So you may, if you call 911, the response you get is going to depend on what your county has agreed to send 4 calls. So some places do have what's called a tiered response. And sometimes if the dispatcher listens to the call and they say, hey, I think it would be appropriate for 2 EMTs to go, you might get an ambulance that's 2 EMTs. To my knowledge, almost everywhere for most of the places here in Colorado, where there is an ambulance service, you're normally going to get a paramedic and an EMT in an ambulance together. And that's called an ALS ambulance, or an advanced life support ambulance. And so you'll almost always be getting a paramedic. The only other exception I can think to that is, so some places where you might have like a volunteer service that provides the initial care and then calls for an ambulance for you. There's no guarantee that everybody that shows up on a volunteer service is going to be an EMT or a paramedic. And additionally, some people will call through their insurance, right? And so like some people might call through Kaiser or whatever, and then the insurance company calls for the ambulance service. And that's not actually a 911 call. It's considered a transfer or an interfacility transfer. And you might get and that insurance service might request a basic life support ambulance or 2 EMTs instead of it being an EMT and a paramedic.
Uh-huh. This is much more complicated than I think any of us imagine. And I'm sure a lot of us are wondering why oftentimes if you call 911 for whatever reason, a health situation, you end up with an ambulance, a police car, a fire truck, which sometimes can be a deterrent, I think, for people to even dial the numbers because they don't want all the hoopla. Can you talk about that?
Yeah. So without going too far in depth, 911 is relatively new as a service that's provided. And so one of the things that's happened over the last 20 to 30 years is the process of what's called EMD, or emergency medical dispatching. And that is what happens when you call 911 and the dispatcher starts asking you questions. They're not saying, when they start asking you questions, they're not delaying the care you're going to get. They're actually giving us information based on a series of questions that they've been trained to ask, kind of in conjunction with a medical director for every dispatch center. And if the call is EMD'd or categorized to be a call that's kind of that's particularly serious, or where it might help the ambulance to have more people to help, or it might get someone there faster, then you might get a fire engine that does have EMTs and occasionally paramedics on it that are trained, as well as that ambulance. And sometimes even a police car, because they might have something like an AED to get there really fast to help do the most good for the people that they're serving.
Mm-hmm.
There is the ability to request what can be called we can say hey, I don't want lights and sirens, or I don't want a fire engine, I just want an ambulance. But it doesn't guarantee that you will only get that, because what the dispatcher's job is to look and say, how sick is this person and what are the appropriate resources to send to this call.
Gotcha. Okay. So it is triaged. And you do have a say.
That's a good word. Yeah.
You can at least put in a say that you would prefer not to have the fire department and the police department, and you could get overridden if they feel like the situation would warrant it. Is that correct?
Yeah, that's correct.
Okay.
Yeah.
Why don't we bring Robert in, if you don't mind, Robert, get you into the conversation.
Sure. Thanks for having me. My name is Robert Putfark. I'm the EMS captain for Arvada Fire. And I've been a paramedic for about 27 years. I worked for a private agency, Pridemark Paramedic Services. Some of you guys remember that. Long time ago, before I've worked for the fire service, and I've been here as the EMS captain for since 2011. And I know Chris very well, so this is a good conversation.
Oh, great. And Robert, I'm going to pause you for one moment. We did have someone ask if we would try to speak more slowly.
I will work on that.
We won't hold you to it, but if you'll go ahead and jump in here and tell us how you fit into this whole system.
So one of the things I think you have a bunch of good questions, and questions are popping up in the chat, and I saw your questions for the panel in your email as well. And one of the things that I think you have to realize is that when you talk about different systems, you're talking about different systems. So the old adage is, if you've seen one fire department, you've seen one fire department. And so the way we do things at Arvada is different than Chris does up in Boulder, just because we have different resources, and we do some of the same things. We do emergency medical dispatch, and we triage calls the way we think it's the most appropriate to send apparatus. And what I mean by that is the number of apparatus and the way they respond, whether it's emergent with lights and sirens or whether it's non-emergent, because when you turn on lights and sirens, people do crazy things when they're driving, and there's all kinds of things that go along with that. But we utilize that same system. We have a paramedic and an EMT on every one of our ambulances. And then we have a paramedic and 3 EMTs on all of our other apparatus. So every apparatus that you get in our system has a paramedic on it. And that's not common throughout the United States. So it is, really specific. If you're thinking about, what's germane to where do I live, is really reaching out to that. Like, I would reach out to Chris if I lived up in Boulder and said, what's the deal in Boulder versus Arvada is a little different. So I think that when you're asking those questions, if you're really trying to get granular, you would go to the fire service or the ambulance provider in your area. There's a lot of similar things that we do that are on your list here that have questions that we do very similarly, but there are differences just based on where you live and how that agency works.
Okay, so that answers someone's question who is wondering about states and such. Obviously, it is very area specific.
Yep, and it's resource specific. That's one of the things, is we have some places have more resources than others, and Chris alluded to, you have some places that you call 911 and the first people you get is volunteers, because that's how, and across the United States, most fire departments are volunteer. People don't realize that. So, but when you, one of the questions that came up, I don't know if it was in the chat or it was in your questions, but somebody said when 911's called, it kind of relates to, why do you get a police officer and why do you get a fire truck and why do you get an ambulance? Mm-hmm. The EMD that goes through, most people don't know that when you dial 911, most of the time in the United States, it goes to a place called a PSAP, or a primary service access provider, which is most often police, because police vet the call first to say, hey, your house is on fire, but did somebody set your house on fire? Is there a threat that police officers have to address? So once they realize, oh, it's a sick person, then they a lot of times will filter that call to the appropriate agency or the appropriate part of their own organization. Like, we're part of JEFCOM. And so when someone calls 911, it'll go to the police side first. They realize, oh, it's somebody's having chest pain, and they'll vet it to the person who will ask the EMD questions about chest pain, and then they'll send the appropriate apparatus for the appropriate agency. Does that make sense?
Yeah, that makes sense. Somebody's asking if we could just walk through, and that could either be Chris or Robert, and Laird, we're holding you in the wings. Would you walk through what happens when if I pick up the phone and I call 911 from that minute on? Can you pretty much ran over that, I think, Robert, that it gets, for you, way it goes to the police department, then the fire department. I think in Boulder County we have a dispatch service. Is that right, Chris? Or
yeah, and so when Rob said that he uses JEFCOM, that's the dispatch center. It's the Jefferson County Dispatch Center. And so when you call 911 in various places, we're pretty saturated with dispatch centers. We have 4 dispatch centers actually in Boulder County that we're utilizing at any given time. And so you could call 911, and if you call 911 and the call is traced to be, out of the city of Longmont, you're going to talk to Longmont Dispatch. Or if you call in the city of Boulder, you're going to talk to Boulder Dispatch. Or if you're on the campus in Boulder, you're going to talk to Boulder CU Dispatch. Or if you're in the various places within Boulder County that are not in those spots, then you're going to talk to the Boulder County Dispatch. And I think what you were asking was, I'm sorry, I was lost. I think what you're asking is, what is the process of calling 911? So when someone calls 911, the first thing that happens is someone picks up that call, and they kind of start deciding, hey, what kind of emergency is this person having? And then they refer it to the appropriate, do their best to refer it to the appropriate resource, right? Whether that's a police thing, like, hey, somebody's breaking into my home. That's, it's a police problem, versus my house is on fire, which is strictly a fire department issue. Like, I don't, as a paramedic that's not working for a fire department, I don't go into house fires, right? Or it could be hey, I'm having an ambulance problem, like I'm hurt, or and then sometimes it's all three of those problems. Hey, this person just cut me off and I got in a car accident, and now I need the fire department to help me get out of the car, and I need the police to help me find this guy that just tried to hurt me, and then I also need an ambulance service because I'm hurt.
Yeah.
And from there, they ask all those questions and then dispatch the appropriate resource. What happens is, I don't know what it is for JeffCom, but typically there's time frames that people say, hey, we want to have the call sent out to the ambulance or the police or the fire department within a certain amount of time. And then the receiving person has a certain amount of time that they're expected to respond to that call and say, hey, we're going to go. And then we have an amount of time to get there. And then we make contact with whoever called and we say, hey, how can we help you? What can we do for you? National response times are typically less than 8 minutes is our goal if you're having an emergency.
That's the goal, is under 8 minutes. Okay. Just quick clarification around the terminology apparatus. Does that mean like the fire truck, the police car, the ambulance?
Yeah, apparatus is kind of like a catch-all term to just describe, hey, this is the vehicle, the resource that we're sending with the people as well.
Gotcha. Okay, thank you. Question about what happens if you arrive and the door is locked? And you've just
So we have there's a couple options for us in Arvada. We have a lockbox system along with Arvada Police Department that people have opted in to say there's a lockbox at my house and it's attached to wherever. It's all in the CAD notes, and the CAD notes computer-aided dispatch notes that come across our information, like our screen in our ambulances and our fire trucks, give us all the information for a certain address. So if they have one of these boxes, like a realtor box or something that has a key in it and it has a code, it will be in that. It'll be in that information so that we could access that. If that's not the case, then we break in if we need to, and PD is involved with that. I think it's very similar up in Boulder, which Chris can talk to, but that's the policy that we do here in Arvada.
So you will break in if you've been called.
As long as as long as we have vetted that it's the right address, it was the right caller. We're not at the wrong place. That would be bad. But yes, we will.
Okay. How about you, Chris?
Absolutely. Yeah, we're following a very similar process. Of course, we'll want police officers there because we don't really want to say like, hey, that person just broke into my home for no reason, right? That would be bad.
Okay.
But we also, and I'm sure this is the same down in Arvada, we use, all the tools at our ability to try and get into the home and do as little damage as possible, although sometimes it's necessary to do damage to that home. So sometimes we'll try and, see if there's a window that's open that we can get through. But we always do want to make sure that we're at the right home first before we go into a home.
And the police department needs to be involved. Thank you for that, because I personally know of someone in Florida who had a terrible accident and called 911, and the paramedics came and the door was locked, and so they left. And she died. So different areas, different ways of things working. Someone in the chat, I believe, said that they do have one of the lock boxes on their front door. Is that recommended by you guys that there be a lock box just in case of emergency, and then you're able
we always suggest it in Arvada, so we can put notes into the computer-aided dispatch that I talked about before that are only visible to the fire department and the police department. And so And the lockbox program actually in Arvada is, and I think Wheat Ridge has it too, actually, is once you use it, if you use it, the police department goes out and changes the code the next day to update it so it's not out there again. And then they update that information in the computer-aided dispatch for that address.
Okay, so to be proactive, you need to connect with your fire department and make arrangements.
Fire and police, yeah.
Okay, that makes great sense. And I think especially people who are living alone.
Yes, yes.
It would be important.
Robert or Chris, do you use in your jurisdictions like a rapid SOS or some type of service that allows the community to put in extra information about coming to their home?
We don't do rapid SOS here, but we have the availability for anybody to contact us, and we will put that information into the CAD as long as it has to be an address. It can't be for a person. So in other words, if a person's at their home, we can have that information that's there. If that person's at Safeway, you know, if they have a specialized medical condition or something that we need to know about, we can put that in their address notes. We can't put that in to follow a person in our CAD system. And I'm pretty sure that's how it is up there, but Chris can talk to that more.
Yeah, that's true. We also offer the ability for people to interface with our fire department and police department and dispatch centers to offer specific guidance for an address, typically not specific to the person. And I did actually see a question about when you call 911 if the dispatchers give feedback or give advice, and that's actually a really good point. That's something I skipped over. Part of EMD is the whole program itself is called EMD, and it works in twofold, right? So the first thing that they're doing is that they're getting information to make sure that the right resources go with the right knowledge, but they're also going to give feedback on certain things. Like they can actually use the phone to listen to breathing sometimes and say, hey, how fast is this person breathing, and give that information to us. They can coach on things like CPR and how to get them to a safe spot to do CPR, as well as, you know, in things like seizure, making sure that you clear the room of things that they could hurt themselves with. The advice that dispatches give with EMD is tailored at the direction of a physician, and it's always designed to do the most amount of good for the most amount of people. So it doesn't always promise that it's not a promise you're always doing the perfect thing for them, but they try and give you advice that's going to generally be really helpful.
Quick aside from talking about tying into people's addresses, when you're using your cell phone, when you're calling 911 from a cell phone from the Safeway, is there traceability as far as location or?
So if I can jump in real quick, and going back to EMD, when you call 911, not a lot of people call 911, and it's usually in a dire situation for you. When I talk to people about this, I usually try to tell them, expect what the dispatcher is supposed to do is they're supposed to ask for your address. The first thing they're supposed to do is they're supposed to ask for your address, and they're supposed to ask for it 3 times. So can you repeat that address? Can you repeat that address? If you're dialing from a landline, which not a lot of people have, but if you're dialing from a landline, there's this thing called Annie Alley, and I have no idea what that means, but it's called Annie Alley, and it shows the address you're calling from. But as you're talking about, you're calling from a cell phone, and cell phones don't have that ability. So, and you're not going to know the address of the Safeway at 80th and Wadsworth. But what you can say is I don't know the address, but I'm at the Safeway at 80th and Wadsworth. And they're supposed to ask that 3 times, which is kind of frustrating if you have someone that's really sick or just got shot or is in cardiac arrest. You're expecting them to get you help, and you're expecting them to give you advice. But they're supposed to ask you the address 3 times, and then they're supposed to ask you your phone number, and they're supposed to ask it 3 times. And that kind of makes sense if you think about it, because if you get disconnected, they have an address to go to. That's the first thing they want, is an address to be able to send someone to. We lost the caller, please go to this. They were talking, frantically. The second thing is your phone number, they can call you back. And then after those things get done, then they finally say the first question of, tell me exactly what happened. That's the start of the EMD process of those questioning. But that first part, they really have to get out of the way, which is frustrating to a lot of people if they haven't thought about it or heard it before, that know that that's going to happen. They can triangulate a phone, like if they need to. Usually that involves PD involvement to actually triangulate a phone, and you actually have to have a good reason to do it. And weirdly, some carriers of phone services have more pushback than others about that. But when you're calling from a cell phone, you might not know where you're at. You might be close, and we get that kind of information. They thought they were at 68th and Wadsworth, and there's a party down, right? And then that's where they send people to.
Robert, by triangulating, do you mean patching in a third person?
No, I mean by patching off of you hit this cell tower and you hit this cell tower over here and this cell tower over here, and those meet up, and you've got to be in this kind of general area with that cell phone ping.
Oh, got you. So sometimes that works as far as locating somebody.
Yep.
Okay. Gotcha. I think we may switch gears to a lot of questions around DNR. This comes up in my work often. People go to the trouble of writing a DNR, having it signed by the physician, or having a most form, having that on their refrigerator, because that's where we're told to put it. We've also been, there's also theory that it would be okay on the back of your front door, because some people don't like the bright green most form sitting on there, stuck to the refrigerator, or the refrigerator is not magnetic, or whatever. So I would like to hear from either one of you, what happens when someone is called to a home. We'll start with just at a home where someone has had a cardiac arrest. They have a DNR. Where are you looking for that document? And then actually, besides the DNR, where are you looking for documentation at all? Are you going to read a whole advanced directive if it's stuck in the freezer? Which some lawyers will tell you to put your advanced directive in the freezer, and that the fire department or the paramedics will find it in there. I'm thinking maybe you don't have the time to be doing that. And then situations where maybe a spouse is there, validly hysterical, saying, please do everything, I can't live without him, but he's got a DNR on hanging in the refrigerator. All these kinds of complications around DNR. And then how does all this patch in with someone like Laird, who's on the other end at the hospital waiting to receive someone? Maybe Robert, we'll start with you and just share with us how can people be proactive? Where should they have the documentation? What can they expect about the documentation being followed, et cetera?
So we suggest on the fridge, we actually suggest a file of life. Looks like this.
Okay.
It's magnetic. This originated a long time ago from a thing called vial of life, which used to be kept inside the refrigerator, not in the freezer. That's weird, but inside the refrigerator. And one of the reasons we actually look inside a refrigerator is some medications are also in the refrigerator. So if we're trying to find out why someone's unconscious, unresponsive, we're looking for their medication list, or we're looking for their medications. That gives us an insight as to what their conditions are. Even if there's someone there, they might not know all their medical conditions. That's why we suggest having one of these filled out with all the medications you're on and your diagnoses that you have. And then that is where we would look for the most form or the DNR.
Hold it up inside the file.
Yep, they just put it right inside there. And the file of life lives on your fridge, or it could live on the back of your door. We have a community risk reduction department at our department, and they do a big push, as do all the firefighters, of getting these in the hands of people and the information to put it on the fridge, because that's where we're going to go and look for it. And so that's where we look for these things.
And can anyone just stop into the fire department and ask for one of those?
Yep, we have thousands of them, and they're in Spanish as well, and they're in Russian. as well, which doesn't really help us, but it helps them. I don't speak Russian, so when I get it, I'm like, but the DNR, I can read that, the DNR in Russian or, Spanish.
And Chris, we have a file of life thing also in Boulder, right?
Yeah, that's correct. And to add to what Captain Puffwork was saying is that we love to see these. This is a awesome thing for people to have. It makes a big difference. It does a couple of things for us. It tells us, your name and your date of birth and some generic information that we tend to need to have on every call. So then we don't have to bother you as many times with, and then how do you spell your name? Hey, I know you're having a hard time, but how do you spell your name? But then also we get information like, hey, what are your wishes, which is really, really important to us. I don't think that we have any formal documentation of, hey, this is where you should look for these documents. It's common to look on the fridge. It's common to see them, like I've never been taught in any part of my training, hey, we tell people to put them in the freezer or that's where you're supposed to put them. But enough people have told me that they put them there that sometimes we just look there as well. So I don't know where that came from, but it does happen. So we try and be, we try and look around for them. You had mentioned like, if you had like a hysterical spouse on scene or party and they were saying, hey, do everything you can, I will be, as honest as I can and say that we try really hard to say, hey, what is the wishes of this patient? What do they want? But also if a spouse is there and they're saying, hey, this is my husband, I want you to do CPR, we will ask about a DNR, but if they say no, they don't have one, or hey, I want you to do CPR, we're probably going to end up doing CPR because that's the norm. That being said, we do, our absolute best to respect advanced directives and having them visible and accessible to us, even if that bright green paper doesn't, match your kitchen aesthetic. It can be really valuable to have it somewhere where we can find it very easily and make a big difference to make sure that the patient or yourself gets the care that you would want to have. I saw a question about what a most form is, and a most form is a form that's standardized by the state of Colorado to express what your wishes are should you not be able to say what you want yourself, in reference to some things like whether or not you would like to have CPR done, whether you'd like to have antibiotics given, whether you'd like to be on a ventilator, and whether or not you'd like to be tube fed.
And for those of you who are familiar with the most form, it's the official copy is in Colorado is printed on Vulcan green paper, which is part of some people's aversion to hanging it on the refrigerator. Just so you know, a copy is also acceptable. A white copy is just as binding as the green form. And what's binding about it is that it is signed by your physician. So the physician, it is a physician's order, which means it needs to be followed. So, you could fold up your copy of the most form and stick it in the file of life and you're covered all the way around.
Yeah. And Colorado's sorry.
No, go ahead, Chris.
I was gonna say Colorado's a really cool state when it comes to advanced directives. I think we're more on the progressive side, and I'm really happy about that. And so if you have written in your own hand in good mental mind written on a post-it note what your wishes are, and it's signed and dated, that's valid. You don't have to have like a attorney sign it for most things. It is good to have your doctor sign up. It adds a layer of validity to your most form, but we're always trying to do our best with what is the patient's wishes. So I saw a question in there about not doing CPR. If the spouse says, hey, don't do CPR, we don't have a DNR, but they don't want it, in that's going to be a little bit more specific to what the protocols of that specific agency or county is. But the state of Colorado does have verbiage in it that says that if you operate with a expressed advance directive in good faith, so if a spouse or a family member says, hey, this is what their wishes was, this is what their advance directive said, that we're actually protected from, from liability there. So we're going to, do our best to validate what you're saying, but we'll also honor your wishes if you're saying, hey, they don't want CPR and you're unable to present that DNR.
Gotcha. We've got a question about how do you decide whether or how long to do CPR, particularly if there is no DNR or the spouse present. But in either case, how do you determine how long? I think this is where Laird comes in, right? You've got the doc on the other at the hospital in the ED on the other end of the line. Is that true? To help lead?
Yes, Sue, that is true.
So
Introduce myself. I'm Laird Wolf, and I'm a retired ER physician. I worked ER for 35 years, the last 25 of which were at Boulder Community Hospital. And I've been on the receiving end of many 911 calls. I've never actually called 911. So what these two gentlemen are telling you is some really valuable and very interesting information. So I would reiterate one of the things I think was Robert said, and that is to have a up-to-date list of your medications, because that is a vital information to the people that will be ultimately taking care of you. And oftentimes the medical record at the hospital in the emergency department will not have an updated record of your latest medication. So having that little piece of paper or laminated with you is so invaluable. That said, if you do dial 911 and the police or fire are not needed and you have a medical issue, you may end up coming to see someone like me. And when you come to the emergency department, it'll probably appear to be as chaos, but it is very controlled chaos. There's lots of people. There's often 2 emergency physicians on at the same time, and anywhere from 10 to 13 nurses, depending on how busy the hospital is. At Boulder Community, that was the case. There also are at least a couple of what are called physician's assistants that are highly qualified people. They don't have MD after their name, but they are every bit as competent as the MDs that you would see in the emergency department. And finally, I would say that what the 2 gentlemen who have spoken before me talk about is called pre-hospital care. And the pre-hospital care in Boulder County and presumably North Denver is really second to none. It is outstanding. Oftentimes, by the time people get into the emergency department to see me, they're already better. So I will leave it at that, and thank you, Sue.
Well, Laird, stay on with you and help us understand if the paramedic is on the scene and there's questions about doing CPR or any other sort of treatment, explain the decision process between you and the paramedic.
Yeah, it's a difficult decision process if there's no documentation of what to do. The paramedics will check to see if the pupils are dilated, if the patient is breathing, if they have a pulse, if they have any electrical activity on what's called the EKG. So they might look at those 3 or 4 things and then relay that information to me. Or they, in some cases, they're able to make that decision on their own because there's simply no reason to continue the resuscitation. But they do often talk to me, but those are sort of the physical parameters that we would ask them about. Are the pupils dilated? Is there a pulse? Is there breathing, etc.?
Thank you. This is kind of hearsay, but I have heard of a friend who was told by a paramedic that no one dies on his watch, no one dies in his ambulance. And so I see Robert chuckling and Chris with it. So that led me to believe that they will do the CPR. They'll do whatever needs to happen to get the person to the hospital, at which point then they can allow them to be pronounced dead. Would you clarify?
So I'll jump in here real quick. So the original question you had, I think that came up in the chat was, when do you stop CPR, right? And we tend to stop CPR after we've gone through certain cycles of what's called ACLS, or advanced cardiac life support. And we don't have a change in the patient's condition. There are, as Dr. Wolf talked about, there's things on the monitor that we look for, different rhythms on the monitor that we look for. Some of the rhythms that we see on the monitor when we first arrive have better outcomes or possible better outcomes than others do. And so when we get on scene, that's one of the first things that we'll look at. We'll put them on the monitor, we'll start CPR. We'll obviously, as we talked about before, look for an advanced directive. If they actually have an advanced directive, and this came up a little earlier in your question, or it was in the chat as well, if they have an advanced directive that they don't want CPR and they present it to us, we stop CPR because they have that, they've made that choice themselves. We want to honor that decision. We might be doing some initial things while they're trying to find that paperwork, or they're having that kind of conversation, but we will work through the ACLS, the advanced cardiac life support algorithm, till one, we either have a pulse back, and we used to do a lot of things in medicine. Dr. Wolf can tell you it's called practicing medicine for a reason. It goes back years and years, and we used to do a lot of different things. Now we don't transport people that we're doing compressions on. We either get a return of spontaneous circulation, or we get a pulse back at the house and we transport those patients, or they have a rhythm that's viable still, and we'll transport those patients. Otherwise, we will pronounce them on scene.
And if they're pronounced, then they obviously don't go to the hospital. Then at that point, it's transport to
the morgue will. So the system in our system, I'm pretty sure it's pretty similar. Chris can talk about this, but in our system, PD is involved on all those calls, and PD kind of takes over the call when we pronounce them. We pronounce them and say time of death was 1650 by Dr. Wolf, because we consult with the doctors and say, this is what we have, this is what we've done. And then we pronounce time of death. And then the police will take over and either have an investigation. If they're doing that, they'll contact the coroner. They'll see if any arrangements have been made with the family of, has there been a mortuary picked, and things like that. So that kind of transitions to a different part of the call. And you guys can talk about that.
Yeah, I can add to that. It's something that I think that's really important to remember, is that, so when we go to a scene, the first decision is, should we do CPR? Should we not do CPR? And we can make that decision based on a variety of things, like, are they beyond the ability of anybody to help them? Or do they have a DNR, things like that? Or is there still, potential chance that we could help them? And if we do that CPR, then we're going to do that CPR, like based on our protocols, again, to the best of our ability. If we elect not to do CPR, then we pronounce them right there, and that's a pronouncement at the direction of our medical director or the doctor that we work with. Or if we choose to work them and we then terminate that resuscitation, that always involves a consultation with the doctor to the best of our ability to say, hey, this is what we have. Something that I think is really important to understand is that when we're on scene, we're normally on scene for, if we decide to do CPR, for about 30 minutes typically. And that time we're spending on scene is to give that patient their best chance of survival. So I think, in the movies, they snatch them up and they throw them in the ambulance and they go, boom, straight to the hospital. And then in the movies, people have a much higher chances of surviving than in reality. And they think that, well, they just need to go to the hospital. That's where the doctors are. But when we stay on scene and we do CPR on scene, we're giving the patient the very best chance that they can have, because CPR in an ambulance while it's moving is not very effective, unfortunately, and does not lead to people getting the best care, and it takes away their chances of having more survival. For coroners in Boulder County specifically, I know that the only time that you would contact a coroner directly is if that patient had already been in the service with a healthcare service that has an agreement with that coroner. So that would be typically like hospice services, where they'll have a form. or occasionally like skilled nursing facilities. All other deaths, you're going to go through the dispatch system, and if it's an expected death, you can still use like the non-emergent number to call the dispatch center, which we can probably find for you, or you would call 911.
And just to add to the so-called out-of-hospital CPR, there's a communication and a trust level between the physician in the ER and the paramedics in the field that I know that they've done everything that we could possibly do in the emergency department, so that the CPR and the what's called the advanced cardiac life support algorithms Robert referred to have been done at least as well as we could do it in the emergency department.
So there's no advantage, certainly no advantage to insisting on getting transported to the hospital.
Not if the paramedics have determined that it's futile.
Gotcha. Could any of the three of you talk about the success of CPR when it's an out of hospital CPR where someone's been found down? It takes 8 minutes for the ambulance to arrive, and then throw in age 70 and above.
Well, I'll go ahead and start. With the advent and the near ubiquity of AEDs, the automated external defibrillators, out of hospital cardiac arrest actually can do pretty well. Some of you gentlemen, Robert might have a better sense of the actual statistics, but a bystander who falls over at the tennis court, and if there's an AED nearby and people do adequate CPR for a few minutes before they can plug in that AED, people do survive and do quite well. We all saw the young man for the Buffalo Bills who had a cardiac arrest on TV, and he's, of course, back playing football. It's a little different when you're over the age of 70, as Sue referred to. The chances, of course, do go down. And if you have chronic illnesses, cancer or whatever, chances are much less. But that's my CPR does work, and the AEDs do work.
I'll jump on Dr. Wolf's bandwagon there. I think really, whether you're going to survive or not is whether you're somewhere to be seen, right? So the highest save rates we have, like in the nation, are some of the airports and some of the casinos, because somebody's at a casino, you're always on camera, right? And somebody's always watching you, and they see you collapse immediately. And then most security guards at casinos have first aid training or are EMTs, and they can start CPR right away, as Dr. Wolf said, CPR right away. And getting an AED, the situation he talked about, we literally had in Arvada last year at the tennis courts, the Apex tennis courts. Guy goes down, his buddy thinks he's funning with him, and then he realizes, oh, they have an AED at the tennis court. His friend does compressions. They put the monitor on and they shock him before the ambulance gets there, which is 4 minutes later. So I think, again, your survivability really depends upon where you're at and being seen, and somebody jumping in and doing compressions. We have a app in Arvada. It's called Pulse Point. And Pulse Point, we were the first city in Colorado to bring it in. And what Pulse Point does is, if you have a smartphone, it tells you within a quarter-mile walking distance of where you're at. So I'm sitting in my office right now up by 80th and Wadsworth. So if there was a cardiac arrest at the target right there, it would suddenly go off and say, there's a CPR is needed at target in a public place. And it would show me where the closest AEDs are. American Heart Association never endorses anything. I'm an American Heart Association faculty, and all of their videos are like, the beginning of it is like, we never endorse, no product is endorsed. If you see products, blah, blah, blah. But in 2018, they changed their, they said items like Pulse Point, using technology with apps such as Pulse Point, can change that number because it alerts people and it alerts them where AEDs are. So it's something that we have in our system. Fort Collins has it, I think. I know south of us in the JeffCom has it now, and it's in, I want to say, 40 states. And it's something that people should put on their phone.
Great recommendation. Thank you.
Yeah. To add to that, like nobody makes it out alive, right? Everybody at some point in time is going to die. But when people don't want to die, right? When they want the CPR, the thing that makes the biggest difference is being willing to do CPR and having that AED available. That is the defining factor, because survival rates are, again, not what it is in the movies. I think I saw in the movies that there's like a 80% survival rate, or a 70 to 80% survival rate. And the reality is that in a lot of places, if you just look at all CPRs, about 40% of the time we'll get pulses back. But really only a small fraction of that percentage are people with brains really going to work and they're going to be able to leave the hospital.
Right.
And the bigger factors in that is going to be, did they get CPR, and did they get CPR fast? And was there an AED available if they needed it?
Thank you for bringing up the fact that there are survival statistics, but survival doesn't necessarily mean functional or acceptable quality of life or acceptable cognitive ability, right? Or it may mean that you end up in the ER, in the ICU, on life support, and you may code again or repeatedly, and then end up dying again in the ICU. Which is why we really want to see people have a conversation with your physician. If you're considering a DNR, that needs to be a joint decision with your physician who knows you, your physicality, your age, your bone structure, your comorbidities, etc., to help you decide if you would want to have a DNR order or a most form on your refrigerator. And or wear a pair of some sort of DNR jewelry. So if you guys could also talk about DNR jewelry, I'd initially been told years ago that it needed to be, the jewelry needed to come from a warden sign or medical alert, where they asked for evidence. They wanted to see the DNR order that was signed by the physician before they would send you your piece of jewelry for $25 or whatever. I think my understanding is things have changed, and if you see a piece of jewelry, even if it was bought on at Amazon or at Walgreens or whatever, you will take that into consideration. How's that looked at?
Yeah, I'd say we do exactly that. It doesn't have to be provided by, a specific doctor or anything like that. As Chris mentioned, we're very progressive here in Colorado, and we want to honor people's wishes. And so, and again, most people don't carry one of these around, although we have these for putting it in your wallet. It's a wallet size one we give out to people as well, to keep inside their wallet. But a lot of people don't carry those. There's an app there's a medical part on people's Apple phones that you can go and search their medical information as an emergency. We don't hardly ever use that. I'll tell you that right now. I don't know about other agencies, but we tend not to, because one, we don't usually have their phone with them. We're talking about an individual and they don't have their phone, or they were just in a car wreck and their phone's somewhere, we don't know. But if they have a piece of jewelry that says, DNR, we will honor that.
Great. Same for you, Chris?
Yeah, that's true. We I was actually, I think it might even be worth pulling up in our protocols. I can just kind of read you a section of what it says, and it's just so you can understand what we're telling our people. And what it says is that EMS providers should try their best to determine a patient's end of life wishes and honor them. These wishes may not be written down, or documentation may be unavailable. In cases where no documentation exists, consider compelling reasons to withhold resuscitation. And so those are going to be the things like if a family member tries to tell us what it is that they would like, or if it's going to be particularly problematic. And then one other thing that I saw just in the chat is, and a question you actually asked earlier, is what are survival rates looking like for people that are over 50, over 60, over 70? And the reality is that, kind of like we talked about, survival rates of CPR is low. Dying is bad for you. It's really hard on your body. And so sometimes we can reverse that and sometimes we cannot. That being said, I wouldn't say, you know, CPR is a guarantee of broken ribs. It can happen. And you have to, as a person, decide what level of risk you want to take. It's not a guarantee that you're going to be brain dead. However, that is statistically what may happen. There's also a chance that you could return to life and have a normal life. And so you have to decide what level of risk you personally want to take on, because there are things that there's a chance that it could happen, right? But I can tell you that, you know, for like my wife, right, I know that she would want CPR done, and even though I know that the chances are not amazing for her, those chances are good enough that I want to try. So it just depends on what level you want to of risk you want to accept.
And just to address the CPR jewelry issue, I don't think I've ever had a patient come to the emergency department as an arrest that had the jewelry on. So I think that's kind of reassuring that they look for this out in the field, and if they see it, they honor it, and they never come to see me.
Ah, good point. Thank you, Laird. Oh,
There was a question in the chat that says, what about medical info on Apple Watch? We actually have utilized that a couple times because it's attached to them, sort of like we're looking for a bracelet of, you know, what do they have for that? And the Apple Watch is easy to utilize because all you have to do is hit the button and hold it, and it's either going to turn it off, it's going to send an SOS signal, or it can ask you if you want their medical information, and you can swipe and you can get that information off their watch. So we have utilized that a couple times for people we found unconscious and unresponsive.
yeah. What are the best ways when a person's out and about, aside from the DNR jewelry and the Apple Watch? There are constants. You wear something on your watch that's got information on it that's accessible. I know I carried bank, a card from DocuBank where all my advanced directives are uploaded to a server, and the information is, there's a little sticker that goes on my driver's license that says I have a card for DocuBank, and then, you know, DocuBank can be accessed 24/7. What kinds of other things are really the most effective way to relay what your preferences are for?
Have a twin with you. Have a twin go everywhere that you go.
Yeah.
I think
ambiguity out there.
Oh,
I
road
think that-
ID. That's what my friend uses. She has a road ID badge that fits
road
on.
ID, yeah, road ID is really popular with bicyclists. I know that, right? Bicyclists and runners, but most people, you know, they don't carry that kind of stuff, and they happen to, you know, fall and at the grocery store or fall on the side of the curb, and we don't have a lot of that information. So, you know, the more we can push out to have that kind of information on you, whether it's in a purse or whether, you know, you're able to put it on your Apple Watch or you're able to wear some kind of ID bracelet, we do look for those kind of things.
Okay.
That would be my suggestion.
Okay. So an ID bracelet is a good way to go, and better than the phone. But that I wouldn't have guessed. I would have thought having your advanced directives and everything on your phone. But you're right. If you're in a car accident or whatever, the phone, you know, in your purse, you're out of the car, whatever. Quick question about DNR tattoo. That always comes up. Will that be honored? DNR tattooed across your chest. You run across that actually?
I've never seen it.
Okay.
I have seen it, and it used to be, again, this is a progressive thing of, hey, we're not going to do that. We're not going to, and again, I can say, if you've seen one fire department, you've seen one fire department. Our medical director is Dr. Beckman. Dr. Wolf knows him very well. And he is of the mindset of, you can't get, unless you're in prison, I think, you can't get a tattoo if you're drunk, and maybe you can in prison. I don't know. But so, you know, you kind of had to have that thought process of getting that and making a decision on it. It would probably be one of the things. I've seen it. It hasn't been on a dead person, but I have seen it. I think that would be one of those. We tend to say phone a friend, and so I'd be on the phone with Dr. Wolf and asking and saying, hey, you know, it depends on the person as well. What I have seen more of that's very more medically related. And yeah, you guys can talk about this too, is I've seen a lot of people who have diabetes and they'll have a tattoo right on their forearm where we're going to go start an IV that says type 1 diabetic. Right.
Really?
And then we're like, oh, that's why they're unconscious, unresponsive. So they're carrying that with them, not in the form of a bracelet, but as of a tattoo.
Has anybody else heard of that? I've never heard of that. What an awesome idea. I mean, as far as just taking care of yourself and being proactive. Constance did mention that the road ID is only $12 a year. And it holds your contacts and medications and all your health information.
Ah, that's,
It's not a bad deal.
yeah.
And it fits over your watch band, I guess. Keeping a DNR in your glove compartment, is that helpful? Will you be looking in the glove box?
So we tend not to at Arvada. Cops are usually looking in the glove box. We have a great relationship with the cops and we've talked to them about that. If they come across something, then they give it to us. But we are more usually inclined to be patient-centric, getting them out of the car, seeing what their injuries are, things like that, as opposed to going through their car and looking for stuff that might come afterwards. So there's a question in the chat that says some EMS agencies do not have cell phone service and are not able to call medical control in some areas. I used to work up in Grand County a long time ago, Grand County EMS, and there were many times they have protocols usually written in that you would attempt base contact, and they usually have protocols that are more robust than the Denver metro area protocols where you have the ability to call, doctors left and right. And so that's usually listed in the EMS agencies, their own protocols with their medical director.
Gotcha.
Yeah, so I can speak to that. We have various ways of also kind of overcoming that. It doesn't always have to be a cell phone. So you can use a radio as well. And sometimes we can even radio to our dispatch, and then our dispatch can communicate or connect us with that physician via phone call. Also, most people have, if they're in their home in a place that doesn't have cell service, have a phone that does work of their own. And so there's sometimes ways to overcome that. That being said, we do also really work really hard to help people make good choices, right? And so sometimes, the joke with EMS is that you're making an educated guess based on incomplete information from someone who's entirely unreliable. And that's kind of like the joke, right? And when you put it all together, it means that we are trying to make really, really important decisions really, really quickly with, again, not the full information. And so we always do our best to help our providers, and this is true across the whole state, just make good choices that are, moral choices and good for the people they serve and also good for themselves. I saw a question about protocols for EMS. There's a national standard for what an EMT or paramedic should be trained to do. And then each state can deviate from that as is appropriate for that state. So I know in Colorado, our EMTs perform a lot of skills that EMTs in other states don't. And then our paramedics, I think, are probably in that, definitely in that leading edge of the curve there for care on an average level. Not if you put it on a bell curve, like they're up here, but they're not. They're on the good side of it.
Okay. Okay, question about how do you guys decide which hospital you're going to take someone to when you show up on scene? And does a person have a say? I really don't want to go to that one or that hospital. I want to go to the one that's got the ice thingy for cardiac or whatever.
That's a great question. Boulder Community, just so you know, is a stroke center, a level 2 trauma center, and a cardiac center. So they can pretty much take anything. But if you're having chest pain or a presumed heart attack, you may not want to go to one particular hospital because they are not as facile with their cardiac care as another one. So the paramedics, Chris can speak to this better than I can. You're kind of obligated to take the person where they want to go, but you also need to take them where they will get the best chance of a positive outcome.
Yeah, I think that's a really good way of explaining it. There's two big facets to it, and the first facet is what's the right facility for this person. And so the way the verbiage that exists is what's the closest, most appropriate facility for the patient. And that doesn't necessarily mean that it's the closest facility. For example, a facility that's more appropriate could have more services that are necessary for that patient. And that's how we make that decision. And so the other side that you have to look at is, oh, sorry, one more thing about the closest, most appropriate facilities. Sometimes people want to go to a facility, say they want to go to Boulder Community Hospital, but Boulder Community Hospital is, inundated with patients, and they don't have the beds, they don't have the resources to really adequately care for more patients to come in. And so they might say, hey, we're full, we cannot take any new people. And then we would be obligated to go to the next most appropriate hospital, making it the appropriate hospital. And so what I always tell my people is we want you to go to the hospital that the patient requests. That being said, there's no guarantee you can go there if that hospital is not accepting people. The other side of it is this thing that I wish we didn't have to talk about, but we do, and it's insurance and whether or not insurance services will pay for that transport and how that all works. So if, let's say that I'm in Boulder and someone asks, hey, I want to go to Medical Center of the Rockies. That's my favorite hospital. It's the best hospital. I would have to, as a paramedic, bypass several hospitals that would be appropriate for your care to get there. And, if you're saying that's the only hospital I want to go to and I refuse to go to any other hospital, if it's a really critical patient, we really will try really hard to encourage you to go to a closer hospital. But you have the right to say, I want to go there. That being said, on the flip side, I also know that it's likely that your insurance will not pay for that change in hospital. And that's a conversation we'll probably try and have with you is, hey, we want you to know that you may not have your insurance cover this because you elected to go to a hospital that was much further away. And then I saw a question about Kaiser. We try really hard, and I know, and I'm just speaking for my system. If someone has Kaiser, we try really hard to go to a Kaiser hospital if we think that person is someone who will get admitted. If you call 911 and you have an emergency that can probably be handled just in the ER alone for stabilization purposes, and then you may be discharged, you can go to the closest, most appropriate ER. But that's again, that's a kind of a insurance specific thing, and that's a exceptionally complicated beast to cover. And we just try and make sure people are making as informed of a decision as we can. And again, this is just my system, so Robert might have other directions that he's given his people.
But Chris,
No,
you're saying
go
as far as being proactive, people should know what hospitals are in their system, covered by their insurance in their
Yeah.
system.
So for example, one thing we run into, and I only know about this because it's happened a couple of times. A lot of major insurances choose not to contract with pre-hospital providers at all. And that's part of just how EMS is. And so, like, for example, Blue Cross Blue Shield will not pay us for an ambulance bill, but they will send a check to the patient for the cost of the ambulance bill. And then that patient is expected to take that check and pay the ambulance service if they do that, who knows? But that's that's how some insurances work versus some insurances will work with us. And so it's a very complicated beast. And I would really heavily recommend that you try your best to understand what your insurance services offer and how it works, and if it does have effect on if you want to go to a different hospital.
Yeah. Great. And Chris, Robert, I think I cut you off when I
I think I interrupted. We do the same thing. The first thing is patient choice. If a patient wants to go to a hospital and it's an appropriate hospital, like Chris and Doc have talked about, for their condition and the timing and everything, that's what we honor. And as long as they're not on divert and they're taking patients, that's what we try to honor, because that was their choice. That's, if someone's having a baby and they want to go to Skyridge, that's a far hospital from us, but they already have their suite picked out and they have their music that they're going to play. We'll go to Skyridge. But as long as the baby's, I don't see a foot or a leg. So otherwise I'm going to go probably quit my job. So, but all the other stuff they said is, yeah, people should know, and we're kind of lucky here in Arvada in the fact of most of the people that we pick up are hospitals in Wheat Ridge, literally like 7 minutes away, and most people that are in our district, they go to that hospital. Similar to up in Boulder, they go to probably 2 different hospitals, and so they already have kind of a choice. So we ask people where they go, and then if they don't know, then we say, well, we ask them about what's going to affect them. What's a good area for you to get, is Wheat Ridge good for you, or is up north better for you to get some help and get picked up from the hospital and things like that. So we'll try to work with them to see what's best for their situation.
Yeah, I think bottom line is you really need to trust your pre-hospital people, your paramedics and EMTs, to take you to the best place that they know they can take you to.
Thank you, Laird. Good point. What if a person doesn't want to go to the hospital and you really, really think they need the care, but they're refusing your free ride? Well, maybe not free.
Well, that's one of the beautiful things about America is you get to choose how you live as long as you're able to understand and make the decision that's appropriate for you. And somebody else doesn't have, like the decision-making capacity or the medical power of attorney over you. You get to choose, and we will do our best to convey the risks and the benefits, and we'll do our best to try and help you make a good decision. But you have the right to make any decision, including bad decisions.
Exactly. Yeah, that's our that's our medical system as we speak. What can a family ride in the ambulance if they would like to?
Yes. Yeah, absolutely. With some ideas of safety, we tend to we have a captain's chair in the back that actually has a 3-point harness that they can sit in and be restrained. And if we can't do that, or we're doing something else, we'll put them in the front seat, the passenger seat, and buckle them in there and transport them if we're doing some, procedures in the back that maybe they don't want to see, or so, but they are more than encouraged to go to the hospital. I think that's been a change for the better of medicine over the last number of years.
It seems like a compassionate choice.
Mm-hmm.
Allow that.
Yeah. We do say, for us, we say it's at the discretion of the provider. So our paramedic or EMT can choose not to allow a family member in. However, we expect that they're going to have a pretty good reason if they say no. So like during COVID, we did have some issues of like, hey, we're really not trying to have more people here because of the, risk of spreading diseases.
Yeah.
And we expect people to make a good decision and be able to justify it and not just be like, well, I didn't really like that person, so I said, no, that's not okay.
Okay. Are you guys trained to handle violent people? I know you deal with this in the ER, right, Laird? I mean,
On a daily basis.
yeah.
Sometimes 2 and 3 times a day. Yes. And it's very difficult because they can be disruptive to the entire department and create a really noxious environment for patients coming in by ambulance, patients who are there, and nurses and everybody. So it's an issue, a big issue. I think Robert and Chris probably see more of this firsthand than I do, which is why when you call 911, you can get the police involved as well.
Exactly.
Chris, you want to jump in there?
Oh, sure. Yeah. So all of our employees take a class that's called EVE, or Escaping Violent Encounters. And it's a standardized class. It's a 16-hour class that involves some, there's some hands-on components to it for like escaping if someone tries to hit you or someone tries to grab you. And it's a standard class that we teach to everybody, and it includes like de-escalation. However, we're in EMS and fire for the most part not trained to, we're not doing any like Brazilian dance fighting, capoeira, or jiu-jitsu or anything like that. We're trained in how to, make sure that we stay safe. And so the other side of that is that when we feel unsafe, our biggest and first most important goal is to not go to places that are unsafe. And that's where we end up utilizing, police officers. So if we feel like it's not safe for us to go somewhere, with the exception of like firefighters are going to take the appropriate safety mitigation tactics, like putting on the appropriate gear to go into an unsafe place like a fire. But if somebody's being violent towards us, we're going to utilize police officers and probably not go on scene until the police officers tell us that it's safe for us to do so.
Do you guys get mental health support, or is it the police? You rely on the police only? Like specific people who are trained in mental health issues?
We do give a lot of mental health support and try and help people get to the right spot. The police do also do mental health support, and there's the increase of what's called co-response or co-responders, and that's going to be a mental health professional along with typically a police officer, but it can be a paramedic or whatever response works. And that's a really cool program that's gaining a lot of traction and very it's amazing. I'm really happy to see it happening in our country.
Yeah, we have a star car which has a licensed clinician and a paramedic on it in Arvada, and most people probably wouldn't guess, but our number one call in the district is falls. People fall, and then the second closest is mental health issues, and then a distant third and fourth are chest pain and shortness of breath, depending upon the season. So yeah, we go on a lot of. I think one of we train everyone in situational awareness. There's been studies that show that your ability to defend yourself, is really your awareness of the situation that's happening at the time. And so that's one of the things we really press here. One of the things that I know Dr. Wolf and Chris and I have all encountered is when you find someone who's in a violent position, and that's not necessarily mental health, sometimes they coincide, but you have to figure out why they're violent. It's not just because they're mad at the world. Sometimes it's a structural issue or a metabolic issue. Like I said, the people whose sugars go to 20, when it's supposed to be 120, they fight people because they don't know any better. And so we really have to take that into account, and we have to assess all those patients of they're a violent patient, but they're a violent patient because of why. And so that's a big part of the puzzle that we really have to figure out along the way.
Yeah, that can be difficult to sort out because it's oftentimes drug related, medication related, in addition to low blood sugar that Robert talked about. I guess in the ER, I should point out that the other patients are really not at risk because we do have the option of restraining violent people in the emergency department, and that unfortunately we had to do on a fairly regular basis just to protect staff and other patients.
Wow. Well, it's nice to hear that at least there's more compassion coming into the system than there historically has been. Is that accurate?
Absolutely.
Yeah.
Absolutely.
Robert, you mentioned falls are the number one reason for calls. Would you mention lift assist and when that's appropriate?
So yeah, so we do, and again, I want to stress this, that if you've seen one fire department, you've seen one fire department. We have a policy of lift assist, so people can call and and we utilize the EMD, the emergency medical dispatch. And this is one of the times where like 80% of the calls we go on as a fire department are medical calls. And so we have 6 ambulances and we have 9 engines or trucks at different stations. So that would be a fire engine or a fire truck, that kind of apparatus. And we only have 6 ambulances. So if you think about 80% of the calls and 6 of those ambulances are doing most of that work, we looked at how can we mitigate some of that workload. And some of the calls when we do EMD, falls is one of those EMD codes. It's a 17 that comes across, and we will send a apparatus, either an engine or a truck, to that call to help that person. We'll assess them, we'll get them off the floor, we'll assess them, and then decide and have a conversation with them of whether they want to or need to go to the hospital at that point. And if they don't want to, we don't, again, Chris said, it's America. People can make poor choices. They do every day. And so they can just refuse and not go to the hospital. And we don't charge them for that. We just say thank you, you know, as long as they have the ability, as Chris said, and the doc said, that they have the cognitive ability to know that they're making that choice. So.
And how does a person get the lift assist? There's a specific number for lift assist, correct?
Yeah, so it would be, no, they'd dial 911.
Oh, just
Yeah.
911.
Yeah,
Okay.
911.
My
You know,
parents.
there was a physician, Dr. Beckman was talking about, and lift assists have become a very prominent thing in the medical field just recently. And there is I want to say, and I don't know the numbers offhand, but there was like a 0.2% of lift assists that were refusals that died within 30 days after a lift assist, and because there's comorbidities and things like that. And he referenced a doctor who was out of Missouri, I think, and the way her quote was something to the effect of, if you can't get your ass off the ground by yourself, and you usually can, that's a problem. You know, so when, so 911 is appropriate. You know, you call 911, you're going to get a response, you're going to get some help, you're going to get an assessment, and you're going to get a conversation of, does anything hurt? Why couldn't you get yourself up off the ground? You know, this is different than a normal thing for you. And so we'll have that conversation. And again, it's really trying to do the best thing for the patient. You know, I worked with my partner for years on the ambulance. His name's Frank O'Brien. He works down at Lutheran now as a respiratory therapist. And I can't tell you how many times I'd be on a scene for a lift assist or for any other thing, and the person that called, or the family, that say, well, what do you think I should do? And Frank would say, never ask a barber if you need a haircut. Right? Paramedics are going to say, go to the hospital. So, you know, and we're going to say, Dr. Wolf, you can figure that out from there. So I think it's just having that the approach of doing the best thing for the patient with a candid conversation about things that possibly could have happened and things we can't do that possibly could be done in the ER and stuff like that. So
Yeah, I look at falls a lot like I look at drowning, right? And so I assume that everybody on here has at some point in time been swimming in a body of water. You know, the question that I always ask is, you know, when was the last time that you found yourself in a body of water and you were unable to get out of it? Right. And so normally the point I'm making is that if somebody drowns, there's probably another cause that led to that. And the same thing as falls, you know, people fall in their homes and they'll be like, oh, well, I just tripped over this carpet, and it's a carpet that, you know, to the best of my ability, I can see has been there for, you know, quite some time. So what changed today that made it so that you fell over this carpet and got wounded? And that's, you know, it's something that we try and be really cautious of, because the worst thing that could happen for us, you know, we would feel terrible if you fell and we said, okay, well, you just, we got you up, and then something bad happened to you.
Yeah, I think of the past 30 years, the one thing that's pre-hospital care and ER care has become so much more patient-centric than it was back when I started. Just to kind of paraphrase what these two gentlemen have said.
Yeah, you've seen that positive change over all these years, Laird?
Absolutely.
Yeah, thank you. Wow, we're at 5:30, and I know we could probably sit here and pick these guys' brains for another couple of hours, but we don't want to press our luck here. Overstay our welcome. Really, really, really appreciate the conversation with the three of you, Chris and Robert and Laird. I think that people, I'm seeing people have gotten a lot out of this. There'll be a lot. You've given them some tools for being more proactive and being able to manage the system in a more appropriate way for themselves, to help them get better care, and for them to have the information that if people are being proactive, then you're going to get more information, the information that you need when you show up on the scene in order to give the best care that you can give. So I think it's a win-win all the way around. I just can't thank you enough. And thank you to everyone who showed up today and who put questions in the chat. Every single question was thoughtful. You'll be getting a recording of the talk within a week or so, and some follow-up along with that, if there's questions that we didn't get to, we'll try to answer them. Nope. We got somebody.
Sue.
Thanks for having us. I appreciate it. I
Yeah.
dropped my email in the chat. If anybody needs has some more questions, I'm more than happy to get to them when I can. So, and Doc,
Thank
it's
you. so
great to
much.
see you again, Chris. Always a pleasure.
You guys were.
Nice
you
to
guys
see you
were
as well.
fantastic. Thank you. Thank you. And thank you from the Funeral Consumer Society to all of you. So have a good rest of the evening. Have a good dinner. And we will see you in a few months at our next webinar.
All
Thank
right.
you.
Thank you.
Bye now.
And so I was going to say, if you have people approach you about a variety of questions, feel free to, collect those and you can send them my way. I'm happy to answer any questions that people have. And I also would throw my email in the chat here as well.
Thank you. Thank you. I appreciate that. We'll send out a follow-up email with the recording for everyone. So if there's questions that were floating around, we can even just throw those into that email, answers to the questions into that email. And if it's okay with you and the other guys, we'll include your email in that, your email address in that email, so that if people have questions, they can reach out directly. But you've been very, very generous today with your knowledge. Thank you.
Thanks so much. Have a great night, everybody.